and we'll be able to go from there. So the next session is entitled Disease-Induced Loss of Function and Tissue Regeneration. Again, my name is Alex Kemper. This next section will really deal with a number of different conditions and a number of different body systems. And I would really challenge you to think across the various talks, what are the common themes that we can learn that inform the goals of the meeting? We've asked the speakers a rather tall task to talk about rather complex disease processes within 20 minutes. And so I'd really ask you again to think about what are the commonalities that go across things. Now, our first talk is going to be examples of GI dysfunction and malabsorption of nutrients, intestinal failure. And Chris Duggan from Boston Children's Hospital will be doing this. Now, he's going to be using the miracle of the internet to come through here. And because he needs to leave, we're actually going to open up his section for questions, and then he's going to go, and then we'll go through the other speakers and try to save those kind of synthesis questions for the end. And now I'm going to point at the screen, and hopefully somebody will make him magically appear.
Thanks, Alex. This is Chris Duggan. Can you hear and see me?
We can hear you like the voice of God, but we can't see you.
Might be better that way. Because I can't see you at all, and it's quite interesting to be lecturing to myself in my own office. I will say, though, that you've all been missing a great spring day here in Boston. If you can't see this, it's a nice snow day here. How about now? Can you see me now? Or we can just, I can just go through the slides. I will say that I want to thank the organizers of the meeting. Obviously, it's been a great meeting so far. I've learned a ton. I think the only good news of my not being able to be there is that for those in the audience that are interested, the course that I'm teaching is a Harvard undergraduate course on nutrition and global health. There are over 120 undergraduate students taking the course this semester, so it's one of the most popular gen ed courses, so there is hope for the younger generation coming up behind us. I've been asked to speak specifically about nutritional requirements in intestinal failure, and one of the actually main ways in which intestinal failure has been defined has been a reduction of functional intestinal mass necessary for adequate digestion and absorption for nutrient, fluid, and growth requirements. So even the people who are interested in intestinal failure as an entity placed into this idea, the concept that nutritional requirements would have to be met by specialized nutritional support, either enteral or parenteral nutrition, to meet the functional definition of intestinal failure. There are three physiologic classifications of intestinal failure. I will speak most about surgical short bowel syndrome, the condition existing from massive resection of the gastrointestinal tract, but gastrointestinal motility disorders, intestinal epithelial defects are also two major classifications of patients for whom the intestine has failed. And the somewhat arbitrary definition of what short bowel syndrome is has been intestinal loss due to acquired or congenital disease leading to dependence on parenteral nutrition for greater than 90 days. The 90-day cutoff is clearly an arbitrary one, but it does seem to correlate with the occurrence of a number of different side effects from long-term parenteral nutrition. Well, just to put pictures into definitions, this is an infant who was born with atretic bowel. You can see lack of vascular development has led to this atretic segment of intestine with dilated meconium-filled bowel proximal to that. This is a patient who's born with gastroschisis, a disease in which the entire length of the bowel may not be shortened, but the function is embarrassed because of poor motility. And this is a patient with necrotizing enterocolitis or ischemic bowel disease who have an X-ray appearance such as this one. Along with Dr. Steeman's point that mortality is really an issue in many patients with chronic intestinal or malabsorptive problems, it's important for us to realize that until relatively recently, more than half of patients with short bowel syndrome either died or underwent multivisceral transplantation. This is a case series of nearly 300 children with intestinal failure who were enrolled in the first few years of this century. And you can see that the mortality rate after 5 years of follow-up was already at 25%, and that competed with the outcome of intestinal or multivisceral transplantation. In contrast, we have these children who progress off of parenteral nutrition and achieve enteral autonomy, and it's generally thought that once they're off of parenteral nutrition, their risk factors for mortality decline substantially. But nonetheless, a 50% mortality or transplant rate was the norm up until recently. As we, as a society, have gotten better at taking care of patients with intestinal failure, you can see that the survival rate has continued to increase, such that some centers are publishing 90% or near 100% survival rates in these children with refractory disease. A few years ago, we actually graphed the odds of weaning from parenteral nutrition, the sigmoid-shaped curve, and compared it with the residual small bowel length. And the inflection point, or the 50% cut point, was between 30 and 40 centimeters of residual small bowel. These were data that were collected in the 1980s and 90s, however. And an update of a similar cohort of patients followed here at Children's Hospital show, in fact, that the inflection point has shifted to the left, that our abilities to prevent central line infections, to prevent chronic liver disease, suggests that children with 10 and 20 centimeters of residual small bowel length in infants can wean successfully from parenteral nutrition. So these are all excellent news for our children with intestinal failure. The treatment of intestinal failure is the mainstay, of course, is early and aggressive parenteral nutrition with increasing frequency of enteral nutrition as the bowel adapts after a massive resection. It really is the mainstay of therapy, and micronutrient supplementation is important as a therapy as well. There are a number of medical therapies for underlying complications of intestinal failure that I won't go into. New hormone analogs for glucagon like peptide 2 are being developed to increase the adaptive process. There are surgical therapies that taper and lengthen the bowel, multivisceral transplantation, but I really always like to say that the tincture of time is the best therapy for intestinal failure because it allows us to guide and support the body's natural process of intestinal adaptation, namely that process where intestinal absorption is improved, where intestinal length increases, and where intestinal mucosal surface area increases as the child gets older. Many children with intestinal failure look like this as infants. They have a central venous catheter in their chest. They have a gastrostomy tube for continuous feeds. And if you look at how different parts of the intestine impact on nutritional requirements, it's really a physiology experiment that I share with my trainees and students, because clearly the place in which gastrointestinal resection occurs negatively impacts on a variety of micro and macronutrient absorptive capacities, to say nothing of important physiological features such as increased bowel permeability, decreased surface area for absorption, hypergastronemia, and others. So the special nutrient requirements are really driven by anatomy in many cases. I won't go through every one of these well-known relationships between terminal ileum and B12 resection, B12 malabsorption, as well as proximal resections and iron absorption. Other complications of intestinal failure, including intestinal failure-associated liver disease, can further embarrass nutritional malabsorption with the setting of cholestasis and bile acid inadequacy. And there are limited data to suggest that fat malabsorption can be worsened in intestinal failure because of pancreatic insufficiency. Well, the crux of this meeting is to evaluate whether nutrition requirements in different patient populations are different from that of a healthy population. And I would certainly agree that intestinal failure patients are really the point of interest in that concept, because indeed they're completely or totally dependent on something that's been misnamed as total parenteral nutrition, right? I mean, total parenteral nutrition does not have all the nutrient requirements. And indeed, as practitioners in the field quite well know, the variety of different nutrient shortages that we've been plagued with over the past several years have illustrated that point in a case-by-case basis. So a number of children in a NICU in Washington, D.C. were evaluated for bacterial sepsis because of their lesions in their hand and feet, and this was related to zinc deficiency because of inadequate supplementation. A case series of 5 children who were on prolonged parenteral nutrition in Seattle had selenium deficiency due to a shortage of that trace element. Our own retrospective review of children with intestinal failure showed that the prevalence of a variety of different micronutrient deficiencies was quite high, even while the patient was receiving parenteral nutrition at least several days per week. When a patient was weaned completely off parenteral nutrition and receiving full enteral nutrition, the prevalence of the different deficiencies actually changed and was also quite high, as you can imagine. And again, this is at a center where we take special care to maintain children on micronutrient supplementations as they're weaning from parenteral nutrition. Now, the American Society for Parenteral and Enteral Nutrition has been, for many years, the main sounding board and physician recommendation publishing group for nutrient requirements in home parenterally fed or chronically parenterally fed patients. And I have a few slides from their recent publication just to illustrate the fact that these recommendations, I hesitate to call them requirements, but their recommendations have shifted over time depending on the nutrient. So concern about manganese toxicity has led to a progressive reduction in the recommendations for daily intake for adults. Selenium recommendations have also changed over time. Chromium recommendations have stayed quite stable, largely because of a lack of data to support what adequate chromium intake has been. And so my point is not to go through each nutrient, but to point out that these recommendations have changed sometimes with data, but sometimes with just opinion. If you look at fat and water-soluble vitamin intakes, the current recommendations for infants and children are presented here. Again, many of these recommendations have been formed by extrapolation from adult data or from extrapolations from animal data. And if you look at trace elements, which is the nutrient class that we've been most recently struggling for with respect to shortages, you can see a wide range of intakes for infants and children. But more importantly, you see a number of important footnotes, such as for copper intake. Well, the authors recommend measuring laboratory data or estimating increased requirements if a patient has burns, or perhaps decreased requirements in the setting of liver cholestasis. Higher doses may be indicated in patients with established deficiency or increased requirements. Well, I would say that that's certainly true of many nutrients. And then there are some nutrients, including iodine, that although a recommendation for its intake is published, it's not currently added to parenteral nutrition in the United States. So what can we say about the evidence base that nutritional requirements in patients with intestinal failure are different from that of a healthy population? Well, it seems self-evident. Obviously, the patients who are dependent on intravenous nutrition clearly have different nutritional requirements, but there, in fact, are very limited data on this point, and they're often derived from empiric observations, as mentioned previously, lack of weight gain, lack of height gain in children and infants, and laboratory data in others. And indeed, the requirements for many nutrients were demonstrated in the early days of parenteral nutrition, and frankly, the later days too, in the setting of shortages, where the omission of important vital nutrients resulted in clinically apparent deficiencies. Obviously, the true requirement of a nutrient is related more to long-term health, and perhaps, as noted by earlier speakers, the prevention of chronic diseases. But certainly in the field of intestinal failure, as you can see, we're still struggling with the amount of nutrients required to prevent clinically apparent deficiencies. Well, the literature is flush with a number of different possibly conditionally essential nutrients in the setting of intestinal malabsorption or in the setting of dependence on parenteral nutrition, but the data is quite weak, I would argue, about a number of these. And in fact, the field is wide open to evaluate the nutrient requirements as patients adapt and get better from their intestinal failure, where weaning from parenteral nutrition is undertaken. We really don't know whether nutrient requirements differ in this regard when someone's transitioning from parenteral to enteral nutrition. We don't even know really what body composition patterns are optimally maintained with different macronutrient and energy combinations of parenteral nutrition. The glutamine field is really a perfect example of that. A number of investigators The animal data, for instance, on glutamine supplementation and the requirement for glutamine in the setting of gastrointestinal diseases is quite voluminous, but when the nutrient was examined carefully in large randomized trials, there was not really any positive effects seen from glutamine supplementation. And I think you could walk back to this slide and look at several of these and compare outcomes in a critically efficient way. I was also asked to address whether the disease state itself or its nutritional status or health-related outcomes is responsive to a specific intervention. Well, intestinal failure per se is really not responsive to nutrition itself unless a patient has severe acute malnutrition or important micronutrient deficiencies, because indeed nutritional support as it's currently practiced are primarily supportive therapies, as I mentioned earlier, as intestinal adaptation occurs over time. A lot of data has occurred recently with respect to the prevention and treatment of intestinal failure-associated liver disease. I would argue that it seems to be related largely to a toxicity of additives that are included in intravenous fat emulsions. As many of you know, intralipid and now more recently quinoleic are the two FDA-approved fat sources, fat emulsions, for the management of long-term parenteral nutrition. Our center and others have led the way with evaluating the effect of fish oil or intravenous omega-van in the biochemical treatment of cholestatic liver disease. We and others are also evaluating the use of smoflipid as a supportive care therapy for patients who are on prolonged parenteral nutrition. So this obviously brings up the issue of whether certain mixes of long-chain fats are relatively required in higher amounts in intestinal failure patients compared to healthy patients. What kind of potential complexities are noted? Are there specific absorption issues? Well, in thinking about future studies, and this has been mentioned previously by people talking about the inherited metabolic disorders, obviously the rarity of the condition makes studies in intestinal failure very difficult. Most of the, at least half of the people on home parenteral nutrition in the United States tend to be smaller infants and toddlers, so there's limited availability for blood volume. Dr. Stover has talked a little bit, and we'll talk tomorrow about valid biomarkers, but blood volume is clearly related to evaluating these biomarkers. There's a huge degree of heterogeneity with respect to intestinal function among different subjects, both with respect to their underlying condition that led to short bowel syndrome, as well as the amount and location of intestine that was resected. And the majority of patients are growing children, so crossover studies are difficult to perform in a growing organism who is hard to be considered to be in steady state. On the other hand, I do think it's important that to acknowledge that patients with intestinal failure have really taught us a lot about nutrient needs. Unfortunately, they've taught it by accident because of the omission of important nutrients in their parenteral nutrition solutions. And indeed, patients with end stomas are easy to do balance studies on. So if people are interested in doing malabsorptive or metabolic studies, I think they are a promising group to evaluate. So that's the end of my formal slides, but I look forward to seeing the audience and talking to some, hearing some questions for my presentation.
Thank you, Chris. That was really great. I'm going to open up your section now for questions. And as people think about their questions, there you are. I can see you now.
Great.
As people think about questions, one of the things that I was wondering, that slide you showed of the inflection point with, how little bowel you need to get off of total parenteral nutrition, that was pretty striking. And I wonder if you can ever foresee the day when when there's a more scientific approach to figuring out what supplements an individual needs. I mean, you can imagine taking into account how old a patient is, how much they weigh, how much residual bowel they have left, and maybe factoring in some other comorbidities and coming up with a formula to figure out how much of these various things they need. Do you think that'll ever happen, or is that pure science fiction?
I think it's an important question to ask. I think that case series like this that have been published have just been done with 30, maybe 20 patients per center, and so that type of prognostic equation, if you will, would need a much larger sample size, I think, to take into consideration so much variability patient to patient. But I think it's a worthwhile thing to think about for sure.
Fantastic, thank you. Does anybody else have any questions right now? Somebody's coming up to the microphone. Dr. Wu?
Hi, it's Gary Wu from University of Pennsylvania. So thinking about intestinal failure or short gut syndrome, I'm thinking it's not just about the absorption of nutrients, but the gut itself makes a lot of products. Peptides, has nuclear hormone receptors, G protein coupled receptors that affect physiology. So I'm wondering if you comment a little bit about the response to nutrients in short gut, knowing that the metabolic homeostasis has somehow been altered because maybe some of that tissue is no longer there.
Oh, sure. Well, I mean, I think the most common etiology and the most promising medication, obviously, for short bowel syndrome is related to the fact of a glucagon-like peptide deficiency, if you will, right? If you've lost a lot of your terminal ileum and some of your colon, you're losing much of the receptors for GLP-2. And so I didn't really focus on medical therapies for intestinal failure, but clearly the analog of GLP-2 has shown promise in adults and limited data available in children. The issue of whether nutrients per se, whether the malabsorption of various nutrients can, if this is what you're asking, can the malabsorption of macronutrients and a variety of malabsorbed micronutrients have a deleterious effect on intestinal adaptation, I think is a little less clear cut. A number of animal models to suggest that vitamin A deficiency, for instance, reduces epithelial turnover, I think have been proven. On the other hand, I haven't seen any data to suggest that high-dose vitamin A improves intestinal adaptation. Zinc is an important molecule, a trace element as well for intestinal adaptation, but at least the animal models suggesting that profound zinc deficiency leads to decreased adaptation have not been borne out either. Am I missing other nutrients that you had thought about in terms of their role in adaptation?
No, I was just wondering more globally that the response to nutrient conditions may be somehow altered just because you don't have a lot of the receptors that you would know. You brought up GLP-2, and I think that's an excellent example. I think FXR and the terminal ileum and the response to a lot of, I think, metabolic homeostasis that people think of when they target that nuclear hormone receptor. If that's no longer there, I'm wondering if that might have a significant effect on the way that physiologically these patients would respond to nutrients in a way that we may not actually see in individuals that have a normal intestinal tract. That's, but I think GLP is a good example of that.
Yeah, no, those are great questions to raise. They're an under-investigated group of patients, frankly.
Thanks a lot. And I think we have time for one last question.
Hi, Bruce Burnett, Red Hill Biopharma. Can you comment on the instance of small intestinal bacteria overgrowth in this population and how it relates to potential liver dysfunction, whether it's causal or associative?
There are some animal data to suggest that bacterial overgrowth does seem to relate with hepatic steatosis. And the problem, of course, with diagnosing bacterial overgrowth in humans has been the main conundrum there. Our group routinely does quantitative cultures of duodenal aspirates to evaluate that in patients at risk for bacterial overgrowth. We have not systematically seen an effect when we treat bacterial overgrowth on liver health per se.
All right, fantastic. I really appreciate your time and your thoughtful comments, Chris.